Just letting folks in. Oops, I've just shut down my I just spent ages trying to get images together and I've just shut it down, which is very annoying. I have to re-Google those now. Oh, come on, where's that picture gone? I'll have to find it in a bit, that's fine. Just wait for some more people to come in. I usually find it takes till about 25 to before everybody's gathered in, which is fine. Hello, folks. Hope everybody's doing okay today. As usual, I'm recovering from 4 hours post-night shift sleep. That's how it always feels at the minute. I'm just going to get a page as well open so I can do I like to keep a track of who's around. There we go. Perfect. Okay, pop that on the other screen, then I can see you all still. Elena. And here. Dawn, I don't think we've met yet, have we? I don't recognise you. Sorry if it's one of my face blindness things.
No, I haven't managed to get to one yet.
That's fine. Hello, Dawn. Welcome.
Hello.
I'll talk to you in a little bit and properly say hi.
Lovely.
I think most other people I know. Lucy, have we met? I'm just trying to see little faces who are all about this big on the screen. No, we haven't met yet. That's fine, Lucy. I'll pop you down as well.
No, hi there.
Hiya, Lucy. Sophie, I know. Lauren, I know. Elena, I know. Sophie, it is Sophie I've met before, the neonatal. Yeah, it is, isn't it? Thank you. Just double checking before I ignore somebody who actually says, no, it's not who you think I am. That's perfect. Okay, we'll give it another 2 minutes because I've still got people trickling in. I was wanting to find a beautiful image of the fourth intercostal nerve, and I had one, and it took me ages to find it, and I've accidentally shut my browser down. And when I'm just trying to sort of multitask here, I can't find it. But hey ho, we'll just see what we can do with that. The fourth intercostal nerve. It's your friend. Is the fourth intercostal nerve? Can I see a picture that I like? Oh, it took me ages. Why did I do that? That's so irritating. Is that one a different one that I can maybe see? It's an anterior view, which is a bit interesting. I like something a little bit more straightforward than that, but we'll have a go with that image and see how we get on. Okay, 35. So I'm just going to stop zooming for images and have a little chat to you all. Hello everybody and welcome to today's tutorial. So today it's about common issues with breastfeeding. So I've got some things I kind of wanted to talk through. I've got some teaching I wanted to do, but I was also happy to be grilled, put on the spot. So for those of you that haven't met me before, hello and welcome. I'm Rebecca. So I'm one of the tutors here at Birth World, and I specifically work on the lactation consultancy course and all the breastfeeding courses. So I'm a midwife, been a midwife 15 years, hence the whole 4 hours sleep after a night shift. I only do one at a time, and I call it a bounce. Don't know if anybody is does night shifts here, but I always do a bounce because I can't do 2 nights together because I sleep so poorly in the middle between them. So I kind of do Sunday, off Monday, on Tuesday, off Wednesday, on Thursday. So I kind of hence the bounce. And most of my colleagues think it's the worst thing in the world, but it's what works for me. So I work postnatally. That's my specialist area because of the breastfeeding stuff. Tongue tie specialist as well. So been a tongue tie practitioner a few years. I don't do that all the time in the clinics now, just because I work freelance. So even on the wards, I just pick up bank shifts, which suits me down to the ground. So I can do all this kind of stuff as well, which I find keeps me a much happier person with a bit more balance in my life than just being NHS out, quite frankly. So yeah, I've been a lactation consultant for the last 8 years or so, but breastfeeding counsellor, peer supporter for the last 21 years, having been there, done that, and got the t-shirt when my own 4 children were babies. So that's where I come from. In terms of how these tutorials work, I am such a person that normally likes to have a PowerPoint. I'm a right PowerPoint girl. I like to have it there, follow it along, do very specific teaching. So it's the first time I've done these for Birth World, and I kind of decided that I'd throw my little PowerPoint Zoom book out of the window and give it a go, just with basically talking about topics I wanted to talk at, things that I thought were key, things that I thought were helpful, but also having the opportunity to hear from you guys and see what kind of topics you wanted to bring to me. So as a tutor over at Birth World, what's really important to me is that I'm very aware that whilst we're getting you through the IBCLC qualification, or the lactation consultant qualification, in terms of the 90 hours of breastfeeding specialist education, whilst that's a very big part of it, I'm also very aware that actually, if you just had it as an online module and you were just learning that and it was just very dry and that's kind of what you learned, that's fine. However, you've got access to me, and I'm hoping that whether you're going to be IBCLCs after it, if you're going to do the exam, or if you're going to be lactation specialist, whatever you're going to do, you're going to be working in this and you're going to be practicing in these areas. So because you're going to be practicing, I kind of wanted to give you as much of my own 21 years of experience as I possibly could do. So looking at scenarios that we see all the time and teaching you, if you're going to be trained by me, let's train you. Teaching you kind of what I've learned along the way. Some people might be breastfeeding specialists in their own right, just not got quite as far as this, might have their own things to add. I'm also really open to learning. If I've missed some evidence coming out, I try and keep on top of as much as I can, but I am also open to being told, actually, I'm not really sure, I disagree. And if you disagree and I still disagree, we can talk it through. Not in that kind of paternalistic kind of a way that sometimes happens when people disagree on a topic and people can't admit that they're wrong. I'm quite open to that. Okay, I know most people, but I just want to have a chat to Dawn and Lucy particularly. Dawn, can I start with you? Is that okay?
Yes, of
So
course.
usually, Dawn, what I ask for is just to know where you are on this journey and why you find yourself here, sort of your background and what you hope to achieve. So those kind of 3 things: where you are, what your background is, and what you're hoping to achieve as a result of doing the course.
When you say where I am, do you mean
Where
like,
you're at in the course. So in terms of the
of
course
course?
physically, sorry. Yeah, it's a very
So I'm
good
doing
question to
the
ask.
breastfeeding counsellor course,
Yeah,
and
okay.
I've done the first 3 modules.
Okay. And
Um,
where's your background?
so I've been a peer supporter for
Right.
10 years,
Okay.
and this kind of feels like the logical next step,
Yeah.
really.
Okay. And what do you want to do with it?
Well, at the moment, I'm still peer supporting and have been for the last 10 years, but also
Yeah.
I'm group coordinator at 2 of the um, breastfeeding groups in our area, and I do that through my day job
Okay.
with Bernardo's. So it's kind of continuing that really and building on it.
Okay. I love that. And just taking that next level. So you're not going to do the full consultant course. So you might just be a little bit lower level. But what you get taught with me on these tutorials, like I say, I am trying to go higher level. So you just
Yeah,
benefit from hearing it anyway. So that'll be great.
brilliant.
Thank you so much. Anything you want to ask me before I jump on to Lucy?
Don't think so, not yet.
I use such terrible turns of phrase. Lucy, I'm on Zoom. I'm literally not actually going to jump on you. You can rest assured about that. I don't know why I can't just speak like a normal human being would and say until I speak to Lucy. So, Lucy, your turn, please.
Hi, I'm also on the breastfeeding counsellor course.
Okay.
I have only been on it for a couple of weeks, so I've done my first module, and then I was just having a quick read through tonight on the common issues things, which
Yeah.
is a bit further down the line for me.
Okay.
But I moved into healthcare 2.5 years ago,
Okay.
and became a maternity support worker. So I did that for 2 years. Didn't quite manage to get the balance with home life with shift work and young children.
Yes.
So I stopped that in July,
Okay.
But I'd really loved the postnatal side of that. So when I went band 3 and core, I was doing postnatal, really loved all
Right.
the breastfeeding side of things. So since finishing with the NHS, I've been doing 2 mornings a week on the postnatal ward as a
Bless you.
volunteering with the infant feeding team.
Yeah.
So really in those first three days of life, and really enjoy that. But I wanted to do the course, one, to just like improve my knowledge, and two, hopefully later on down the line, as my children are at school, it's something that I can develop, even with whether that's a job with the infant feeding team, that would be the dream, or maybe even the lactation consultant.
Okay. Perfect. That's really helpful. Thank you so much. So you know well what it's like to only have 4 hours sleep, I'm guessing. As long as you did night
Yes.
shifts too. Yeah. Always fun. Okay. So what I want to do today is I like it to be interactive. So you can use the chat, you can turn your mics off. I know it's always a bit awkward when we kind of talk over each other, but it really doesn't matter. I just want to know what people think of when they think about common issues, particularly anybody who's been in that breastfeeding world already and is living that. What do you think of as the main issues that you come across frequently?
Mastitis is a pretty common one.
Good start. Thank you, Elena.
Usually people worrying about their milk supply and that they've not got enough milk.
Yeah.
In general, nipple pain and
Yeah.
latching pain.
Yeah, absolutely.
Tongue ties.
Yeah. Yeah.
We've had
Visual-
loads of people asking about reflux recently. Every baby's got reflux.
Yeah. Yeah. Actually, all babies do have reflux technically. So that's an interesting one as well. Okay. Anything else that jumps out at anybody?
In the first few days, there seems to be a lot of sleepy baby going on, and jaundice.
Yeah.
And the knock-on effect of that.
Loving that. Anything else?
Had a few blebs recently.
Yeah. Oh gosh, yeah. Milk blebs. They're really painful as well. I had such a classic one the other day. She could have taken the photo for the textbooks. Go on, Sophie, were you going to speak?
Thrush. It seems to be. Everyone seems to think they've got thrush as soon as they see white mouths on babies.
Yeah. Well, it's just that coating on the tongue that so many babies end up getting as well. Thrush, when you actually see it, when you're sort of learning about it and you're hearing about thrush, and you sort of think, is it thrush? Is it not thrush? And then when you see a case, you're like, okay, like it becomes so chalk and cheese different. You've got Belle over your head.
I have. I'm sat in the children's room while they're watching telly nicely, hopefully, for the whole hour.
They look like they've got beautiful murals on the walls. That's absolutely gorgeous. That's gorgeous. Okay.
I was going to say, sorry.
Go on, go.
Weight issues as well. So baby's not
Yes.
gaining weight as expected.
And all of these things that you've just talked about, the first thing that jumped out at me is how they're also interrelated. Like, I don't think I'd even seen that myself. I think until I'm sort of hearing it back, I'm just thinking, well, that's because of that, and that's because of that. And all of these issues, it becomes kind of like a web, and everything is so interconnected. So baby not gaining weight, not having enough breast milk, having sore cracked nipples, having mastitis, all of it just completely tongue tie. They all can actually just become one part of the whole thing, because what you've got is a pathological problem in terms of it's just not working for whatever reason. So what I always love to do, and I think I might have briefly mentioned this on a previous tutorial, but I can't remember if it's the one that wasn't recorded. So on the basis of that, I want to talk about it again, but I want to talk about it in a bit more detail. The bottom line, and things that I love, if you go to some midwives, okay, and you say, if I ask them this question, why do you need a good latch? Okay, I'm going to get the following answers. I'm going to get because it's going to help the baby get a good transfer of milk. It's going to make sure that the baby gains weight well. You might hear them saying it makes the feed more efficient. And you'll probably say because it protects the nipple. They're probably the main things you hear when you say it, okay? But then when you say to them, why? Why does it do those things? Then you might hear, sometimes you'll hear about the junction between the soft and the hard palate and the protection of the nipple being deeper drawn in and the latch not being right. So it goes a little bit further, but you never get the full histology of what's actually happening internally in the breast and with regard to the baby's latch. And that's something that I think You get it a little bit from the learning on here, but sometimes it's quite hard with the individual things that we're looking at in the LC world on these courses to actually put it all together and see it as a whole big picture. So that's something I wanted to kind of gift to you, because I think it's one of the most important things if you're going to do any breastfeeding work at all. And that is understanding why we want to have that good latch. Not only what the good latch is, but really understanding why, and understanding, okay, those things happen, that the baby gets a good transfer of milk, that the baby has a more efficient feed. But let's go further. Let's go into but why is that happening? Okay. So I'm really annoyed with myself that I didn't think to bring up my breastfeeding bag today. I thought it was up here, but it's not. But that's fine. I'm very good at using my hands as various aids and things like that at the minute. So if we have we're thinking about our breast, and we're thinking about how the brain gets told, because we now know that the brain needs to get the messages and get the signals to release our oxytocin, and our oxytocin is going to initiate that letdown of milk, isn't it? Just as a bit of revision for you, can somebody quickly tell me how that happens, what the letdown is on a more biological terms? It doesn't matter if you've not got really detailed words, just how the letdown happens. How does the letdown happen? So nobody brave enough. That's okay, because I know it's always that thing of I think I know, but I don't want to say it and sound stupid to everybody else. I get that. Okay, so we've got our breast, and in the breast we've got all our milk making tissue. Within that we've got our bunches of grapes like structures that form our breast milk tissue, a breast milk making tissue. We've got our bunches of grapes with our little alveoli in. So the alveoli is where the milk production happens inside of it. On the inside of the alveoli, sort of inside that grape, it's all lined with the milk producing cells. So all those cells work together, and they, of course, what do they make milk from? It's not a trick question. What does the milk get made from?
From blood, isn't it?
Yeah, it is exactly right. Thank you very much, Dawn. You see, it wasn't a trick question. It's an easy one. But sometimes we just need to think about those basics. So we get that really good milk supply in the breast when we just had a baby, because we're sending so much blood to the breast, because that's where it's going to manufacture the milk from. So on the inside of it, you've got the epithelial cells, which are going to have the actual milk producing, milk manufacturing lactocytes. Okay, perfect. On the outside of the alveoli, we've got our myopithelial cells, which are all muscle contractors. So basically within them, they have got your little oxytocin receptors. So all hormones, I always talk about it, and it's good to understand it from my perspective, because then you can explain it this way to women and birthing people, lactating parents. Okay, so if you think of hormones as kind of like a key, and the key is literally released into your bloodstream, and it floats around your entire bloodstream looking for places where that key can fit into. So there's your locks, okay? So if you think of all receptor cells as a lock, so a key for oxytocin will only fit a lock made for oxytocin. So that's a receptor cell that's the right shape. And it's literally very mechanical like that. It literally fits into place. Once it's fitted in and that receptor receives that message, that tells the myopithelial cells we're going to contract, and that's what causes the letdown. So those muscles on the outside of the alveoli squeeze. So you've not got a baby latched onto the end of your breast here trying to get milk from the top of the breast tissue here. They're not using all their negative pressure, so suction being negative pressure, they're not having to rely on sucking to get the milk right back here. What they're going to do is, as well as having that negative pressure, they've also got that force to force the milk towards the ducts, towards the baby's mouth, which comes from your oxytocin letdown. And that happens because the oxytocin has floated around your bloodstream. It's looked for places where it can fit, because it'll go into your toes. The oxytocin doesn't like no to go just to your boobs. It goes everywhere systemically, but it finds the oxytocin receptors in those myopithelial cells, and it tells them, okay, we've got an instruction now, we're going to squeeze, and that's how we know to let down milk. Perfect. We know that works. Excellent. But how do we make sure? How does the latch make that happen? The other thing that we've got going on as well, every time your baby suckles on the breast, so here's my little booby and here's my baby's mouth, we're suckling. We get receptors within the nipple and the areola themselves. Okay, they're almost like mechanical stretch receptors. Okay, so when they are being suckled on, they're effectively being stretched, and that is like an on switch as well, and that sends a message, which is why I was looking and I haven't been able to find it, and I'd love you all to learn this, particularly the people on the LC level, is it's your fourth intercostal nerve. Okay, so that is what innervates the breast. That's the nerve that kind of gives all our sensation, all our messages to our breast, and receives the messages from the breast as well. So it goes along that fourth intercostal nerve, back up your central spinal cord, up into your brain, finds the area of your brain where it says, okay, the pituitary gland, where it says, right, we're going to release the oxytocin. We've got a baby suckling. And that knows, okay, we've got the message that a baby's suckling. What do? We release oxytocin into the bloodstream and we release prolactin into the bloodstream. The oxytocin has got that brain effect as well, because oxytocin also makes us feel all loving and mushy with our babies, and you kind of, have that bond with your baby. So it's really good, because if you just had this baby that was waking you up all the time and you weren't getting any sleep and you didn't have any of that loving stuff going on, you'd be worried for the baby's survival, because it'd be very easy for a parent to think, stuff this for a lark, I'm not doing this anymore, and abandoning the baby. But all those loving feelings come as a result of it. So it goes into your brain and has all that lovely effect, but also it goes into our bloodstream and tells our cells to squeeze that milk out. Perfect. We love that. The other thing that's going on is you've got your prolactin hormone being released, and prolactin does what? What instruction does that have? Again, it's not a trick question.
Make milk.
Yeah, perfect. Awesome. So and it's literally just like an order that comes in. So again, it floats around looking for the receptor that fits the prolactin. Okay. There's lots of stuff about prolactin receptor theory that is really interesting, but just given where we're at with it, I probably don't have enough time to go into all that as well. But prolactin receptor theory is really interesting. So it basically comes into our breasts. It finds the prolactin receptors, which are inside those lactocytes, those milk producing cells. And it says, great, we've got an order. Let's start manufacturing the milk. And that's when it happens. Brilliant. So if we've got a baby that is really well latched onto the breast, it's going to send a really strong message, because it's going to hit those receptors in the right places. It's going to really send a strong message along that fourth intercostal nerve to the brain, which tells our brain to make enough milk, to produce enough milk to sustain this baby at the basis of how much the baby's wanting to feed, and to also help the baby get the milk out with the oxytocin. Brilliant. If we did not have a good enough latch, therefore, so say the baby's on a shallow latch, as well as what's going to happen to the nipple, which is going to cause all the other things we've talked about. We increase the risk of mastitis if we're not draining the breast properly. We increase the risk of mastitis if we've got any cracks, which allow bacteria to track back into the breast and actually cause that infection in the first place. Tyan's just arriving. I'll just let her in as well. So we've got all the stuff going on from a mouth level. But brilliant, it's saying, okay, this baby is feeding, so we need to know to make enough milk for our baby. If your baby's got a poor latch, and I'll talk about the nipple stuff, like I said, separately, and hasn't got that deep latch like into the breast like it should do, sort of beyond the nipple and into the areola, with a nice mechanism that's really, really well sealed, and telling that breast to send those messages to the fourth intercostal nerve to tell that hypothalamus, the pituitary gland, that we need to release the oxytocin. Okay. If that doesn't happen, we're not going to get enough prolactin. If we don't have enough prolactin, what do we not have enough of? Milk. Yeah, I can see people mouthing it. If we don't have enough prolactin, we don't have enough milk. That's the bottom line. And that's absolutely what we need. So if you've got a baby that's feeding and feeding and feeding, it isn't getting good prolactin signal sent. So it's not receiving good prolactin. The breasts aren't going to manufacture enough milk. What's going to happen in terms of the efficiency of feeds?
It will diminish.
Yeah, because the baby's going to need to be on that breast a lot more to get the same amount of milk back. So they're going to have to work harder, because the messages are so much poorer, to get the same amount of milk back. What's going to happen to our weight gain, so we've got two things. We've got people worried about milk supply there, and we've also got people who are worried about the baby's weight gain. Can you see how those two things immediately linked? I mean, that's aside from the kind of perception about milk supply being a whole other thing. But if we do it in realistic terms about people not actually having enough milk, babies not gaining enough weight, this is often what we're seeing. Does it make sense to you why that's happening? Has anyone got any questions so far? Happy? Good. Awesome. Perfect. So if you want a baby that's going to gain weight, that's going to feed 8 to 12 times in a 24-hour period for an appropriate amount of time, so that the parent, the mum, the breastfeeding parent, gets enough time off in between to do life as well, and doesn't feel like they're just sat there feeding constantly for a baby that isn't thriving. That's what you need. You need a really, really good latch. Okay, so we need a good latch for efficient feeds, for less frequent feeds, for good weight gain, and ultimately for good milk supply, because of that how it initiates the nerve stimulation in the breast. If we've got a shallow latch, we're not going to hit those nerve endings, and we're not working on them properly. So what the baby does when it latches on is has that wide open mouth. As we know, we had the chin that hit the chest, like we talked about last week, or 2 weeks ago, and then the tongue sticks out over the lower gum. The tongue comes underneath the nipple and the areola, and it spreads thinly. As it spreads thinly and the baby then latches on with that top lip over the top of that area, it forms a seal, and the tongue is essential in forming that seal, and that nice thin seal area. So then, as we're working that nipple, we can draw it far enough into the back of the baby's mouth to make sure that we don't hit the hard palate of the mouth. We then hit the soft palate of the mouth. Perfect. Absolutely everything we want to be happening. When it hits the soft palate of the mouth, it's going to be protected, and the tongue has a nice peristaltic wave action underneath it, which helps to draw the milk out and also helps to stimulate those nerve endings when the baby is suckling. So everything is working so much better, which is why the latch stuff we talked about 2 weeks ago, and having the baby really close and almost like you're wearing the baby rather than holding the baby as a separate entity, is so important, because if a baby isn't nice and close, they can't get as much into the mouth. If they're sort of leaning for it, it's never going to be as good as if they just can have it just there and the mouth is nicely filled with breast tissue, which is exactly what we want. What do we think is going on with our nipples then? Okay, so we've got that tongue. Now, instead of the tongue drawing that nipple into the back of the baby's mouth like that, like we want it to happen, it sits here at the front of the baby's mouth. The baby hasn't got a good mouthful of breast and it can't stabilize the nipple. The first thing the baby does is it clamps down with its gums. So often you hear people talking about feeling like it's chomping. That's a really good red flag. It's also why we hear what noise if we don't have a good latch?
Clicking.
Yeah, clicking, exactly. Because if we don't, the clicking is, oh, suction lost, oh, suction lost, oh, suction lost. We want that maintenance of suction, don't we, going on? So if we're hearing that clicking noise, we need to think, actually, is this baby maintaining this latch? Is there a loss of the suction? Why is that going on? Then you'll see lots of babies have a blister here and certainly here. You see lots of babies with these now it might be that you've got quite a good latch and they're just rubbing a little bit and they still get somewhat of a blister, but the ones with the poor latches, you see it all the way, and parents just think it's normal. They start to see it as just the baby's lips with that kind of puffy blister because they don't know any different. So that's something worth bearing in mind as well when you're looking at your babies and you're thinking, this has got a really big sucking blister, this is really significant, I can see it all the way. Probably the baby has potentially just been clinging on for dear life. Meanwhile, the poor nipple in the mouth, instead of being taken back to that soft palate junction where it's nicely protected and nicely worked and it just stays still, it's kind of worked and milked underneath by the tongue, instead of that lovely, that's my nipple here, like just been sitting there, just been worked, it goes like this at the front of the mouth. And if you I think I showed this the other week, but for those of you that weren't there, just doing that, you can feel heat starts just in your own hand. Now imagine that really sensitive skin on your nipple doing that for a 40-minute breastfeed. You can understand exactly why that crack forms, can't you? So therefore, we've got a baby that's going to create sore nipples. So you're going to have a parent that doesn't want to breastfeed, that wants to avoid it like the plague, who's actually having to sit there more frequently and for longer because the baby's feeding less efficiently. And all the time they're sitting there feeding inefficiently, not getting the prolactin to make enough milk. They're not going to have a great milk supply. The baby's going to be losing weight. You've got a parent whose nipple soreness is only going to exponentially increase and increase and increase. Agreed? Yeah, perfect. And so that is why we need a good latch. Okay, so if you can explain those things to parents in a kind of a way that is based on that individual person, there might be language barriers you're dealing with, there might be difference in kind of academic understanding and things, but just using that language in a way that it makes sense to them rather than they just need a good latch, because sometimes it really helps them to think, okay, so that gives me hope that actually if I can get that nipple far enough in the back of the baby's mouth, things are going to be better. So linking it up with what we talked about, so we talked about people not having babies that weren't gaining weight well, people who had poor milk supply or perception of it. I'll talk about perception of poor milk supply as well today. But we've also got the nipple damage going on. We've also got that avoidance of wanting to breastfeed. There's so much stuff, it's all going to a perfect storm. But one thing we haven't talked about, say we have got a really good hold, so we've got a great position. Say the baby looks like it's latching great. So from the externals, it looks great, but we've still got a crack. It's really painful. We're seeing weight loss. We're seeing a baby that we're seeing a poor milk supply. What other thing might be going on that we haven't thought about that was mentioned at the beginning of class today?
Poor tongue function.
Yeah, exactly. So that comes down to our tongue ties. Okay. So as a breastfeeding counsellor, it's not necessarily, and even as a lactation consultant, we can't officially diagnose a tongue tie. That needs to be the diagnostician, so a tongue tie practitioner in that place. So even although I cut and divide tongue ties, in my role as a lactation consultant, I can't officially diagnose it. What I can do is I can strongly indicate that I think there may be one. These are my reasons for it. You can do additional training that allows you to assess tongue function. For those of you wanting to IBCLCs, I would definitely, do that additional training. So that you can at least say, well, I can do a tongue function assessment. We have things like the Hazel Baker. That's one that most people, picture just randomly fell down. The Hazel Baker is one that's very often used. I would definitely have a look at that. And the Hazel Baker is a scoring system. So for the Hazel Baker, we have a functionality and an appearance score. And then it's a very subjective test because the functionality is based on what the baby can do in that particular moment. Now, the tongue is a muscle. So the tongue can get tired. So it could work really, really well at the beginning. So you might assess it and think this tongue function is great. But that baby 40 minutes into a breastfeed, 20 minutes into a breastfeed, because we don't sit there assessing it for 20 minutes. It's quite a quick assessment. So you have to always make it clear that it's a subjective assessment and that it can change based on how the baby ages. The baby's anatomy can change, but also how the baby feeds at a particular time of day, how tired they are, how tired the tongue physically is. That can change that assessment score as well. So what we say is we'll give you a score. So they have separate items on the, in fact, let me find you the Hazel Baker and I'll show you what I'm talking about. Has anyone used Hazel Baker? No.
No. We use the Bristol Tabby in.
Yeah, so the Tabby's that's a really early one. So that's kind of your let's do it to refer people in.
Yeah. Okay.
So I'll show you that one as well. And this is more what you're going to use if you're going to be doing the tongue assessment before division. And if you were going to refer people in saying, actually, I think there might be a restriction here in how the baby's tongue is working. I'm just going to try and open this up.
Do you actually have to be a doctor to actually create to do an incision?
So no, you just have to be a health professional registered to do it. So you have to have had appropriate training to do it. So as a midwife, I do the incisions. And to be fair, the incisions, I literally just cut it. Has anyone seen tongue ties being snipped?
Yeah, my own.
Yeah,
Not me personally. My
exactly.
first child.
So we do them with scissors. So yes. They're all different in different places, but literally it's about isolating the lingual frenulum. So that's what your tongue tie is. Oh, don't worry, Suzanne, you're absolutely fine. And that's a very good excuse. She said I had my diet with hypnobirthing and mindfulness workshop. Oh, bless you. Well, you're very welcome to be here anyway. So yeah, when we isolate it, we then can literally just get your scissors around it and you literally just can cut it because there's where you're cutting, there shouldn't be any nerves. That's the aim in the lingual frenulum. However, what you've got to be careful of, and what we do know now, so they looked at some cadavers. Do you know what? My brain is I know the name of this research. It's just completely gone out of my head. I'll kick myself after this. But they looked at some cadavers, and what they found was actually there is a lot of nerve innervation there under that tongue area. So what you have to do when you're doing that cut is you have to be confident that you're just cutting lingual frenulum, that you're not going to cut into the base of the tongue or anything, because what could happen if you're cutting nerves? I mean, I know you're not doing this, but it's just good to understand it, I think. If you're cutting nerves, you're going to cause potential loss of functionality of the tongue, which is exactly the reverse of what you're trying to achieve, and pain. Now, if you've done a tongue tie division and you've got a baby with pain, it's really not a good situation to be in, because then you've got a baby that is struggling with the pain of that division and then might not feed, and you might get oral aversial completely and breast refusal, bottle refusal even. And at the very, very worst case scenarios, if you've done too big a cut or there's any damage caused and the baby's been a bit traumatized by that and too much pain, you end up with a baby being NG tube fed, which is just horrifyingly traumatic for the families involved and, you know, those decisions. So you have to know that the person who's going to be with the scissors knows exactly what they're doing and they know the right size of cut to do. So I'm going to just come back to the tongue tie stuff I want to talk about and what actually happens with how the tongue tie affects that nipple soreness. I'm going to just divert, or do you want me to divert just to explain where they come from, the ties?
Yeah, it's such a big issue around where I live. So yeah.
Okay, so again, I'm going IBCLC level, folks, okay? So this is just above and beyond the normal kind of training stuff at those lower levels, but let's go to the top. So embryology, how we are formed when we have embryos. So, you know, we start off as that little blastocyst, the ball of cells, and then we start to differentiate. Very early in that differentiation, you get a split, okay? Initially, the tongue is all fused to the base of the baby's mouth. They don't look like a baby at this point. They're looking in that little kind of prawn stage. What should happen as part of the embryology and development is that tongue will separate from the floor of the mouth as part of that, okay? Now, when you've got the lingual frenulum in the middle, that it's basically an incomplete separation all the way back in the embryology phase. That's how far back it goes. So initially, if you think of it as being like a central tube, so we start off, it's a neural tube defect officially, because that's the midline that we have through our body. That's where our spinal cord is developed. And so it's a little bit of a failure of that to divide in the way it should do, which is why sometimes they're a little bit tighter. So they just don't quite divide at the very, very early phase. So we can have lingual frenulums that are really tight. They can go all the way to the tip of the tongue, and they can nearly seal the tongue to the floor of the mouth. I mean, they're the worst case scenarios. I hate them when you can't get your fingers under the tongue to lift it. I need enough space with my scissors as a practitioner to be able to see the gap between the floor of the mouth and the base of the tongue. If I can't see that, I'm going to be very, very worried about it. So, but the worst case scenario is you haven't even got a scissor width to do it. You need to have a really good visibility for that. I wouldn't be doing it as a midwife. I'd be sending it surgically to be divided at that kind of level. Very often there's quite a bit of stretch on the tongue, so putting 2 fingers underneath the tongue and lifting up, and that gives you that little bit of space that you need. Sometimes the frenulum doesn't go all the way to the tip of the tongue, it's sort of a little bit further back, but this is where our beautiful functionality, and this will fit really well now into the share I'm about to do for you here. So this is the Hazel Baker I was talking about. You can see that, can you? Should say assessment tool that you haven't got my just checking you haven't got my list of who's here. My attendance list screen. I'm just going to check. Yeah, I'm sharing the right thing. So functionality is here on the left-hand side or the top. So we go through and we get points scored 2 to 0. Okay. Lateralization is how the baby's tongue moves from side to side. So nobody can diagnose tongue tie unless they're a practitioner, but you can do an assessment like this with a little bit more training. So you'd probably just need to work with someone who's already doing these. That would class enough as your training. So if it's something you're interested in, you could ask someone, you know, if you could shadow them and learn about this as part of your IBCLC. It's an IBCLC level of stuff rather than a breastfeeding counsellor, but breastfeeding counsellors, you should understand how it works. So when people are talking about it, you can understand it. Lateralization is how a baby's tongue can move side to side in the mouth, okay? So does it completely move? So if you put your finger at this side, does the baby's tip of the tongue, can the tip of the tongue follow my finger? Can it follow it to the other side? Is it complete? So I get 2 points for that. If the body of the tongue is moving, but the tongue tip isn't quite reaching it, that scores 1 point. And if it can't follow my finger at all, I'm a 0, okay? Lift of the tongue, that is how we can lift the tongue up underneath, like how high we can lift. You know, when the baby's crying, is it going all the way? Like ideally, you should open a baby's mouth when they're asleep, and you should see the top of the tongue sealed to the roof of the baby's mouth. That's what we're looking for. That's an ideal thing. That's always a really reassuring thing if I can see that. If, however, when the baby's crying, the tongue is still very low down in the mouth, you're thinking, okay, why is that tongue anchored so low? So I probably would store that. If I saw a baby that wasn't lifting its tongue up, I'm going to score that as a 0, okay? If it goes, and I've looked and I've opened that mouth and I can see the tip of the tongue all the way to the roof of the mouth, we're going to get a 2. And if it's somewhere in the middle, so we can see the edges pulling up, but the middle of it's being anchored, that's going to be a 1. Is this making sense to people? You don't need to remember it all precisely. It's just understanding the mechanism of how this stuff works, okay? The extension of the tongue, so people often think the baby's tongue sticks out, but if it only actually is going to lower gum, that isn't sticking out, that would be a 1. A 2, we have to see it extending past the lower lip, okay? A 1, we can extend it to the gum, and a 0 if it isn't even getting to the gum, okay? The spread of the tongue, that's about that spreading thinly that the tongue needs to do in order to bring that nipple in far enough back and cause that protection that we want it to have with that draw. Complete spread, it's really spreads thinly. You can see that by, if you tickle your baby's lip and you see it'll start to stick its tongue ready for that breastfeed, and you should see it spreading thinly. If you've got a thick, bunchy tongue, that is going to be a 0. Okay, if you've got somewhere in the middle, it's moderate, it's not great. You might not even be able to feel it when you're doing a suck test, and you can feel it's still a bit fat and bunchy under your fingers. It's probably going to be a 1 or a 0, and a 2 if it's a beautiful thin spread. Okay. The cupping of the tongue, so when the finger goes into the baby's mouth, as the nipple should, the tongue should have come up around the sides of the nipple to provide a channel, and that's part of that seal that it forms within the baby's mouth. So again, if you've got a good cup, you can only feel that by actually doing a sort of suck test with your finger. If you've got a good suck, it's going to be 2 if you've got that good cup. If it's a little bit, but it's not very powerful, it's a 1. And if it's not cupping at all, it's a 0. Okay. The peristalsis, that's the wave action. Sometimes I've felt babies, and actually it's so bad that it's pushing back out of the mouth rather than drawing in. Because if you can think about it, if you want that nipple to draw into the baby's mouth, the wave needs to draw it to the back. If the wave is pushing it outwards, you're never going to get anywhere with it. Okay. And then you snap back, that's your clicking. So that is, the tongue might be able to come and do that. It might be able to spread thin. But if the tongue is struggling to maintain it because it's got that anchor pulling it backwards all the time, you're going to get that click. And you can feel that as well. You can literally feel it sort of ping back when you're doing a suck test with it. Okay. So that's your functionality. So your maximum there is, I think, 2, 4, 6, 8, 10, 12. Yeah, 14. I didn't want to get it wrong. So we've got a maximum score of 14, and that would be a perfect function. It's still subjective. Somebody else could do it a different day, and the baby might not be getting the same score, okay? Then we go to our appearance. That's what the lingual frenulum looks like, okay? So if we've got one of those classic heart-shaped tongues, so when they're trying to stick the tongue out, you see that big heart shape or a bit of a snake shape at the end of the tongue, it's going to be a 0. If it's just a little bit of 1 like that, just a tiny pull in, you're probably going to give it a 1. And if you've got a nice rounded tongue at the end, you can give it a 2, okay? When we lift it, how high does it lift? Is it anchored to the tongue within a centimetre and you can't lift it more than a centimetre, or can you lift it more than a centimetre? Okay. The attachment of the lingual frenulum to the alveolar ridge, so that's your gum line here. So when you put your finger in and you sweep across and you feel that lingual frenulum, is it attached to the top of the gum, or is it attached to the base of the floor of the mouth? So if you think about what I've just told you about the embryology, see, it's all starting. I hope that all this big picture I'm trying to give you is all starting to weave together, and you can see why I say it's all part of the whole thing. So when we don't have that separation, it comes, so it's all the way to that gum line. It hasn't even separated onto the floor of the mouth. It just hasn't separated. And sometimes you can feel it right on the top of it actually is coming from the top of the baby's gum. I've got teeth in the way to show you, but it comes right the way to the top of the gum, and that's a quite significant tie as well. How elastic is it? Have I got a bit of stretch on it? Or is it really like, no, it's quite rigid and it doesn't want to stretch? And the attachment of the lingual frenulum to the tongue, so that's underneath the base of the tongue. Is it to the tip of the tongue? Is it halfway back? Or is it quite far back in the baby's mouth? Now, sometimes the lingual frenulum is not a really easy one to see. So you can see the signs of it, you can feel the poor function, but when you're actually feeling underneath, the frenulum, it's not one of those, what we call a noticeable visible frenulum. It's not noticeable, it's not visible. Is it therefore sort of submucosal? So all the mucosa that sits under the base of that tongue, all that mucosal layer that we know exists, is there a frenulum that's actually really tight, that's sat behind it and that we can't see? They're a little bit harder to cut, so they're a little bit higher, slightly higher risk in terms of reattachment. Potentially high risk because you can't necessarily see the blood vessels in there. I'm just checking what those texts I've just seen two come through. With the training, will I still not be able to give a diagnosis? No, Tayan, we wouldn't. I don't diagnose as an IBCLC. I only diagnose as a tongue-tied practitioner. that's something that I would say about that. Yeah, the start time is 6:30 for these now, Vera, because they've got a 7:30 class that starts. Thank you. Just catching up with that, but it's fine because they're all recorded now, so we're absolutely fine. So yeah, it's really about being able to put it all together and think about what you can see. And if we've got a more posterior one, you get a bit more scar tissue when we cut into those. And with the posterior ones, you tend to get a big diamond shape because you're cutting into that mucosa more. And when you've cut it, as you cut there, kind of like, I always think about those cards that you used to do when you were a kid, and they turn into like a triangle and they make like a beak shape. It's a bit like that when you're cutting the lingual frenulum in terms of this big diamond shape that you'll see. An easy one to the front of the tongue, you're probably not going to see that diamond shape. It's going to be much easier to just cut it. Potentially you can cut that, get the tongue to release, and it's just much easier for the baby. So if we've got a tongue tie, we can't spread the tongue thinly. We can't draw the nipple into the roof of the back of the baby's mouth to protect that nipple. They don't have the good latch. They don't have the good stimulation of the nerve endings like we know that we need. And then we start heading into all these problems. We start to get cracks. We start to get damaged nipples. With damaged nipples, we have the potential that bacteria, because the baby's mouth's going to have bacteria in. It's going to be bacteria. We've got our own microbiome on us. If we get any bacteria that's a bit more pathological that gets inside that crack, it's going to track inside those ducts quite easily, and you're going to end up with infective mastitis. So someone's just asking how you train as a tongue-tie practitioner. So you need to be a healthcare professional to do that generally. Nowadays, I believe that you have to be a healthcare professional, I think, rather than an IBCLC. So you can do the training to like go a bit further with the lingual frenulum. Basically, if you've had anybody that's taught you how to do this in practice, you've got clinical experience, you can do the assessments as an IBCLC, but you can't still diagnose it. And to be a tongue-tie practitioner, I did I've got a master's module in it before I did it, and then I got trained by a surgeon to do it. So it's a bit of a different level. But to be honest with you, it's a really scary thing to be doing. And I would want to do it with my full NHS team available. If my baby bleeds, I've had a bleeder and things, and it's not a nice thing to happen at all. So you kind of want that full NHS team available to make sure that the baby stays nice and safe. So I'm hoping I've given you a big picture. The other thing about mastitis that we didn't mention, there's sort of two forms of mastitis. There's the bacterial infective mastitis, but there's also, oops, it says I've signed out. You're all still there? I'm looking at me. So why is it saying your session's ended? That's weird. You can all still see me.
Yes.
I'm going to stop the share and just ignore the weird message. As long as you can still hear me talking, I'm good. Yeah, so basically, the other type of mastitis is basically if the ducts have been so blocked, or there's been a lot of engorgement, and potentially those ducts burst a little bit, and you get some inflammatory mastitis because basically the milk has spilled out of the ducts into the surrounding breast tissue. So it's not bacterial infective, which means technically, unless it becomes bacterially infected, antibiotics aren't going to work, because antibiotics are only going to work for bacterial infection. Just while we're talking about common issues, anybody with mastitis, especially if they've had it more than once, I'm going to always ask for them to get a milk sample taken. Always. And as an IBCLC lactation specialist, you can suggest they ask for that. Why am I asking for a milk sample to be taken to the labs?
A white blood cell count.
Yeah, but it's the milk. It's not the white blood cell count. It's what's actually growing in the milk itself. Your white blood cells would work for you, though, for sure. If you were doing that for yourself to see if you've got signs of infection, if you've got raised infection markers, yes. But from the milk point of view, we can grow cultures out of the milk, which means that if there are any bacteria in there, they're going to grow in that laboratory environment. We find out what bacteria is there. I've actually seen really sinister, I've seen GBS and stuff growing out of it, E. coli. I've seen all kinds of things coming back that was actually in that milk. So if you're using one type of antibiotic that isn't going to be effective on that kind of bacteria, they're going to have recurrent bouts. They're going to be consistently going on the antibiotics. It's not really going to be clearing up properly because you're not using the right antibiotic. So it's really sensible. And although you're not a medical practitioner, you can say, I would ask them to take a milk culture sample. Just take it in, you take it in just one of the little white pots and ask them to test it. It's called a culture and sensitivity test they need to ask for. And I would do that for anybody, particularly if they've had mastitis more than once or it's not a clear reason. or you're not convinced that the antibiotic is working effectively, and they're not always great at sending those milk samples off to check for that. It depends on the GP or, the practitioner who's doing that work. So I've given you a lot in sort of 50 minutes today. I've given you a lot of kind of higher level thinking with common conditions that we're seeing. I wanted you to start to see the connection between it all, because if you see the connection, you know why the basics are really important. Any main questions, just so we've got 10 minutes, although it does say I'm signed out, it's very freaking me out. 10 minutes just to see if there's anything else you want me to cover that I haven't talked about.
Sorry, can I just confirm? So these sessions are starting at 6:30?
Yes, they weren't initially. They changed them because of the other classes that they've got going with Birth World and ATI. So yeah, but they're recorded now, so you can come back and pick up the recording.
Okay.
It'll all be available. I can send you the link if you want it later. Just email me and I'll send you the link for the page, which has got all the recordings on it.
Okay.
So yeah,
Can I
it's
ask...
just a thing.
Oh, sorry. Just you mentioned earlier about sort of keeping up to date with evidence and that kind of thing. Is there like a place, like I feel I don't really know much about it, but is there like anywhere that's really good for like keeping up to date with sort of latest evidence and all that kind of
baby friendly? I think keep an eye on the baby friendly website. Now it might not turn into practice as quickly as they're learning about things. Sometimes things take a few years before we're seeing them on the shop floor, but baby friendly is going to publish evidence and information on there, and that's where I got a lot of my research papers from. It's weird because they might publish the research and they're still not doing it even in the baby friendly stuff, but again, it's the bureaucracy that then comes as a result of them changing policies and procedures, and then that's got to filter down to the hospitals who are doing baby friendly. But that's a really nice starting point. NHS stuff as well. Any links from the NHS? There was some good private people, but I wouldn't want to recommend private people to you. I think we'll stick with the ones. Kelly Mom was amazing. They were always so good and evidence-based, but they're not running anymore either. So I think stick with baby friendly for your research stuff, and that's a really good starting point.
Thank you.
And if you can do like annual baby friendly initiative.
Baby.
Oh, it's a really good website. They do an annual conference as well if you get a chance to attend it at any point. Any kind of conferences as well. There's all kinds of places that do. This will be for your updates anyway when you get your IBCLC exams. For those of you taking the exam, you can go on the conferences and you've got world-renowned researchers very often talking on that. Like Hazel Baker herself goes and talks at those kind of events. There's an amazing tongue-tie practitioner who's a friend of mine in the UK. In fact, I'm just going to give you her name as well. 1 second. I'm just seeing if I can find her practice name for you, because she puts a lot of stuff out and I really like her stuff as well. The Association of Tongue-Tie Practitioners is a good place to look at as well. They probably share evidence. I hate the menopause. It's the ADHD or the menopause or both together. I can never remember. So this is somebody whose stuff I talk to her and I see her and I message her and her name has just completely and utterly gone out of my head, and that's really annoying me. Let me just see if I can remember. Oh God, why does it do that? It's so annoying. Oh, why is your name not coming to me? She's written the most amazing book as well, which I would definitely recommend on tongue tie. And it's a really easy read, and I can't think of what she's called. Oh, sorry, guys. I'll have it ready for next week. Don't know why. My brain is just completely and utterly farted on you all. Sorry.
Sorry.
But she's really good. She's got a great book.
I had a question about the last thing you spoke about, the milk culture test. Would we be able to advise to get one as IBCLC?
So you can advise them to get one as an IBCLC or a breastfeeding counsellor. It's perfectly reasonable to say, if I was you, I'd ask your GP to do a breast milk culture test. We can't order them, but we can direct the person that we're supporting to ask for one from the healthcare professional.
Oh, okay,
it's Sarah. So I feel so bad that I forgot her name. Sarah Oakley. Of course, it's Sarah Oakley. I'm just going to show you her book. In fact, I'll just put the link in. I would highly recommend this because this also links in with a lot of the things that come together as well. Oh, that was the other thing that was mentioned at the beginning, reflux. So I just want to mention reflux, unless there's anything else anybody else wants me to say before we finish, and I'll go off in that direction. So reflux, okay, all babies reflux. It's kind of natural that babies will regurgitate a little bit of milk. The problem with pathologizing reflux, as in making it abnormal when it's within the parameters of normal, is that babies then get medicated. The medication for reflux is not the best in terms of the fact that actually it can cause more gut problems for babies, quite a lot of gut problems when it's overused. Gaviscon, for example, should be used for babies that need it, that really need it. So, of course, reflux, the idea is that the flap over your esophagus isn't quite closing properly. It's a little bit immature. So instead of kind of closing when the food is in there, it's a bit too loose and it kind of flaps about and opens up, and babies have got a lot of acid burning up. Babies who've got true acid reflux, they smell acidic. So when you smell the baby's breath, they're not just like that milky smell. It's got a real sour, acidy smell to it, because they're the ones where and they can get some burning in their esophagus because so much of the stomach acid swells up with it. All babies don't have a perfectly closing flop over the esophagus, so they do get this little bit of reflux. They can overfill a little bit and it can come spilling back out in vomit. You can lay a baby down and it's not completely closed, and it sort of, they bring some air up and then it brings a load of milk with it. That isn't true reflux. But if you've got a baby that is really, really settling, struggling to settle, really crying, is obviously in pain. The other thing that people call reflux all the time that I find is a baby that lays down and starts to cry when it's laid down, and when you're holding it upright, it's fine. But I'm smiling at it because that's also a baby telling you it wants to be held, because babies are made for contact. Babies are made to be held by the parents all the time. That's our reality. It's not our reality in our modern day world where we don't have that cave woman floor. I think I've talked about this before in class, but we don't have that cave woman floor for them to lay on, where there's no mattresses, there's no duvets, there's none of those dangerous things for babies. There's no drugs in labor, all those kind of things. So babies biologically know that they want to be held all the time. So if you've got a baby that screams every time it's laid flat, but it's great when it's held and picked up, it doesn't mean it's reflux. Does that make sense as well? So reflux is and it is important to use. We can use like various PPIs like omeprazole and things. Protein pump inhibitors can be prescribed, but they should be done for the babies that have got true reflux. And some babies do, but I would say it's a much smaller percentage of babies that actually have true reflux than the number of babies that are being diagnosed with silent reflux or different things. We've got to think about what's normal for babies. Yeah, the Carol Smith book is really good on reflux. I like that one, Dawn. That's a really good recommendation. Is there anything else anybody wants to say about reflux before we finish?
How do you sort of tell the difference between what is true reflux and what is?
So if your baby is generally quite happy, has some feeds, sometimes it's still hungry after a feed, sometimes it's not literally, you can just tell the difference between these babies that you go to and they are just screaming all the time. They are so cross. There is nothing you can do to placate them. They are so unhappy, and they do have this really acidy smell when they're sort of burping, and when you even just on the breath, it's really different. But if you've got a baby that just cries a bit, doesn't want to be put down much, that is absolutely not enough to say, that vomits a bit, spits up a bit. That is not enough to say that baby's got reflux. Silent reflux is a thing. It does exist, in my opinion. There are babies that aren't going to actually show that vomit who are refluxing and have got that acid sloshing up into their esophagus. And it does burn. It does cause problems for babies. So there's no wonder babies are really unhappy with it. But I think it's the difference between what's within our not, and that's experience, I think. What's within the normal parameters of babies do cry. Some babies are a little bit happier. Some babies are at the edge of that, within that sphere of normality. But there are certainly babies that go beyond that sphere of normality with it, and you think, okay, and because I can often think, babies do cry though, because I'm trying not to over pathologicize babies. I can often think that, and I'll be presented with a baby, I'm like, no, this parent knows what they're talking about. I can completely see what they say. This baby's unconsolable and it's screaming. This baby's got pain. Where is the pain? Is it a gut pain or is it a reflux pain? The baby's actually vomiting a lot. We can smell that acidicness. Maybe this baby's one that we need to think about a PPI or Gaviscon and see how it goes. But what we don't want to do is cause more problems and constipation and things by using things that actually aren't necessary. And if you think about who brought out this idea of reflux, it's really sad. If you actually look at it, it's all in the book, I think Carol Smith's book from memory. Can you remember that, John? That it comes from the pharmaceutical industry. So it's in their best interest that people believe reflux is a thing, because then there's more Gaviscon being used for babies. Oh, shocking, really, when you actually put it together. But when you put it together, it makes sense. Doesn't mean to say it doesn't exist. It just means to say that it doesn't exist in the numbers that we think it does.
I think in the book it said that 0.14% of babies have true reflux.
Yes.
That's like
tiny.
Just over
tiny.
1 in 1,000, isn't it?
It is about 1 in 1,000, but you meet about, well, certainly in the world that I see, 30%, 40% of people who think the baby's got reflux.
I feel like half our
300 or
babies
400 in 1,000. Yeah, say that again, Sophie.
I feel like half the people that we come across and work on the neonatal unit are all convinced that they've got reflux. We end up prescribing.
And it's too early in the neonatal unit, Sophie.
Yeah,
it's way too early because it's so immature that it would be normal that a baby doesn't have a mature esophageal flap. It would be normal at that point. So it's not. And then it carries on, and then we get into our, when we're in formulas and we're having the formulas that are thicker and horrible things that are meant to stay in the baby's tummy better. And it's like that because it's thicker. Ugh. It's not what the babies were meant to have. It's not kind of the solution, I guess, that babies were meant to have in the breast milk and things. So anything else anyone wants to ask or say? The other class doesn't look like it started, so we have got a few minutes if you want them. But if you're happy, I'm happy.
Can I just quickly ask, as a mother seeking help, who does she turn to? Is it a breastfeeding so having issues with feeding? Is it a breastfeeding counsellor? Is it an infant feeding specialist? Is it a lactation consultant? Who would she turn to?
I think you've just talked about the ladder really well there. I think you've just described it. So often you'll find that they'll go to NHS levels. Initially, that's going to be your midwives. Then your midwife has signed you off from that service. Maybe they'll go to health visitor groups from that point. Maybe from that, they go into the peer supporter level, then the breastfeeding counsellor level, if it's above what the peer supporter feels comfortable with. Dawn, you'll know those kind of cases where you think, actually, bit of position and attachment, I can do it, but actually this one isn't fixing. We can't just fix that. Maybe the breastfeeding counsellor, when the breastfeeding counsellor thinks, actually, I think there's something going on with mastitis, I think there might be a potential tongue tie there, then you're going up to IBCLC status. So it does kind of climb up the ladder. Some areas do have charitable groups where there's an IBCLC who can get paid from the funding of the group. So in our area, people can, when they've got funding in place, there's an IBCLC attached to them who gets paid by the funding, so they get grants. She takes the grant money and she can see the people, so actually it's free access to an IBCLC. But otherwise, unfortunately, it's a paid thing, which frustrates the heck out of me. But equally, you're all paying a lot for this. You're going to pay a lot for the exam if you're doing it. You're going to pay a lot for your CPD. You want to do this instead of going to work. You're not going to do 40 hours like this as you could do in your workplace. So if you're going to be, making this sacrifice to do it for, say you give up 10 hours of your work so you're available to do this 2 hours a week, you need to get paid more per hour. That's how it works. So the rate is really nice, but then it's horrible for the people having to pay for that. But equally, that's just kind of like, why would you charge £30 an hour? You can't afford to do it for £30 an hour either. They're all things to think about. I think it's cheap to get somebody for £110 for, a visit, really, and a lactation consultant level. I think that's quite a good rate. And there's people charging a lot more than that.
Sorry, did you say £100?
£110 is probably, quite a low rate in my area, and I'm in the north. That would be considered one of the cheapest.
Okay, so what's the upper end?
Potentially, you might have people, probably when you're getting more into the tongue tie assessment phases, £200 for consultation. So for example, mine is 110, but I didn't like that because I feel highly uncomfortable with it. So I call myself like an IBCLC in your phone. So I go and visit them. I do that initial thing. I take a lot of information beforehand. I have a nice comprehensive form that gets filled in before. So I've got a lot of the details I need. And that means I can reflect on it, do any research, look at the evidence. If I think I need to look at something specific in that particular area, go out to do my visit. And then I stay in touch with them for 2 weeks. So I say we have a WhatsApp group. And I usually get both parents, if there's two parents involved, to join the WhatsApp group. And for 2 weeks, they can send me videos, ask me questions, and I'll reply. Some people, you fixed it, they're fine. They tell you everything's great, you don't hear from them again. Some people, you're speaking to a bit more, but that's easy because it's just like when I'm sat on the loo, I can quickly write a message or whatever I need to do. So I feel like it gives them some follow-up, because what I don't like is IBCLC to go out, attend, fix it there, and then they're stuck. And what you don't want ever, you always want to have, like we talked about in the positioning and attachment, you always want to give them a step by step, because what you don't want is to people to be find that they've kind of, somebody's come and they've fixed it, but they don't know what to do to repeat it. You need that very clear step-by-step process for them to know exactly what you've done differently whilst you were with them, so that they can repeat that when they're on their own without you. That's something that I think is so important, and that's how I always teach and train people as IBCLCs, that you need to leave them with a step-by-step guide, and we never touch anybody's breast, even if they offer it to you. We just don't do that. You don't need to do that. I absolutely don't need to do that. At the level I'm working at, I never touch anybody's breast, apart from if it was literally diagnostic as a midwife and there was a pathological problem with the breast. I would never, other than that.
Can I just also ask, so you use a comprehensive form. Is there like a template online?
No, I don't, not that I found. I literally, so the history, do you want me to give you that? Are you interested, all of you?
Yeah,
I mean, if you want to go, that's probably, I'm going to, feel free to jump off, but I'm going to give you some things that are on my form. Okay. So we need, obviously, all the details that we're going to have, and we need to have a GDPR disclaimer on anything that you keep, that they've agreed for you to maintain the details for the purposes of the breastfeeding support you're giving them. And on the form, I try to take as little detail as possible. I take an email address, phone number and address if I'm going out to see them, and I take first names on that form. Then I take what number baby it is, and then health-based questions. So what gestation the baby was born at and the date of birth of the baby. Family history of allergies, that's really important. Family history of bleeding disorders is good if you're going to start to ask them about tongue-tie division. If that's something they might want to discuss with you, you need to know that. And then anything hormonal. So there's things that aren't common issues that I don't talk about today that are on the course. So there's lots of hormonal things that can cause problems. So for example, if you've got polycystic ovaries or if you've got hypothyroidism, that might affect your milk supply. So we want to know about any hormonal conditions, including difficulty getting pregnant. It's a big form. This is why, but then again, you're not sat there doing it in the meeting. You've had chance to find, and if they say they've got some weird, I've had some pituitary gland tumours and things like that, you want to have read up on it beforehand. So it gives you a chance to do that rather than not being able to give them good value for your time.
Sorry, Rebecca. Thank you so much. This is all very useful information. I was wondering if you had the template of this form that you could share with us. Like I wouldn't be happy to share
it other than verbally, if that's okay. I can understand why you're asking, just because of kind of like for my practice, if then you use it and then people said, oh, well, this wasn't included, it comes back to me because I've shared it with you.
Oh, I see what you mean. Yeah, sure.
So I kind of came up with it. So I know there's a lot. But again, it'll be on the recording, so you can come back and listen to it again if you're not getting it all written down.
Thank you.
So I do appreciate that. It's just, it's really hard. As an IBCLC, you have to protect yourself so much because you're not working under that NHS umbrella anymore. You're working independently. You've got your own insurance. So you have to be really careful. So even when I'm talking to you, I have to be really careful about what I share, whether I'm sharing your medical information that I can't share with you and things like that. So, do you want me to carry on, folks? Do you want some more of the things on that form? Okay. So we've got all the information about hormonal conditions. You also want information on any breast surgery that's happened in the past, reduction or breast enlargement. You want issues like if they think that there's any problems with the breast, So we're thinking about glandular tissue there. It's very, very rare, which is why I don't bring it up on common issues, but I find glandular tissue is really interesting because some people don't have enough milk and it's because they don't actually have enough breast tissue. And they might have known the breast wall is a bit different shaped. Or so you're asking people's perceptions of any issues. You might want to know if they think that the problems are caused by flat nipples, large breasts, large nipples. You want to get that information beforehand so you start to think about it. Then we're going on to the baby's birth.
Can I just, sorry, based on the breast, what about breast cancer?
Anything, any pathology of the breast, anything that they've had, any breast reduction, because that will usually include breast surgery. So any breast cancers, usually they've had at least a ductectomy or they've had a lumpectomy at the very, very least. So that will all come under that. But good question. I like the way you're thinking. So anything with any surgical intervention on the breast or anything that they perceive, even if they don't know, even if it's not been diagnosed, sometimes it hasn't been diagnosed, but they know something isn't quite right. So it gives you a chance to think about those things. And then we go on to the baby's mode of birth. Massive impact. I think it's on the course as well, just about babies that might need some body work, craniosteopathy, for example, if the baby's had a difficult forceps birth or they've been stuck during labour. These are all things you want to hear about. You can ask them the questions in person, but I do find that it's a bit of a cheat, but you've got it all written down, so you don't have to sit there writing as they talk to you because it's already been provided to you. And again, you've got the GDPR and you have to keep this on some sort of a OneDrive that's got a password protection on it, just to bear that in mind as well. So it needs to be password protected. And then when you're not looking after them anymore, based on whatever your GDPR policy is, you need to delete that record that they've sent you.
Is it same as NHS records or sort of?
No, I think for this processing, it wouldn't be the same as NHS. For this, you will keep them as long as you are needing to, work with them, and you can send them copies of things so they retain copies. It's hard. It's a difficult thing because you want something, but if they want you to delete it, then you delete it. You could say in your GDPR, I keep it for 3 years. But unless you ask me to delete it sooner, but it's just that processing, what you've got to do to cover it. It's something probably we could do a whole session on GDPR really, but it's just to highlight it, that it's a thing that we need to be careful of.
What kind of insurance would you say you need? Like what should it cover, or if there's a specific type that we should look for?
So I use a block insurance. So I'm part of in fact, the best one I can tell you about, it's not the one I use. Lactation Consultants Great Britain, when you qualify, you become a member there and you can get insured through their block insurance policy. So it's much cheaper than getting individual insurance and it's covering the IBCLC caseload. So it's a really good question and it's affordable at that. It's not unaffordable. So we've asked about baby's birth mode. And then you're wanting to know about those early feeds. Did the baby have a breastfeed straight after they were born? Who fed the baby? Was it within an hour? Was it skin to skin? What could have gone wrong at the very beginning we're thinking about here? That might, if you know that the baby's had a delay from feeding, and you've now got somebody who doesn't have good breast milk supply, is it because they formula fed for 4 days at first? Did they have a late start? It all makes sense to you as to when you're making those decisions and giving them that advice later on and giving them those recommendations and guidelines. You can't advise as a peer supporter. When you get into this sort of lactation consultant world, it's a little bit more like, this is something you can try. We're still using that language, so we're not giving advice so much, but in reality, it's a bit more advisory than in that peer supporter world where you might use language like, other women have tried this, other people have found this has been helpful. Your language can change slightly as to, this is what we might be looking at. I can see that this might be a thing, and these are things that you can do with this problem, and then they can choose to. And this is what the plan is. You make the plan with me. If you're happy to do that, we'll write the plan down, because that's what you are going to keep a track of during that appointment, is what the agreements are, what plan you've made together. So then it's a case of what happened in the early baby's feeding history, and then we want to know weights, what the baby's birth weight was, what weight they lost or gained on day 3, day 5, and since then in the most recent weigh-in. This is all just off the top of my head as well. You don't realise how much you know until it all starts to come out. So we're trying to get a really good sense of the history. Then it's literally like, tell me about your feeding experience so far. I have a list of problems to say, what do you want advice on? And I have all the things that we've talked about and some: milk blebs, mastitis, recurring mastitis, not enough milk supply, baby feeding all the time, cracked nipples, sore nipples, whatever it might be. There's a big long list, and they can just delete the ones that aren't appropriate, and they can add things in themselves. That's what they want. So you're very clear about what they're wanting from you, because sometimes you can hear a history and you don't actually know what they want to achieve from that consultation. It could be that actually they're just wanting help on a baby that doesn't take a bottle, and they're wanting to leave the baby so they can go back to work. You could be in that phase. It's just which phase of the world you're in at the time. So that gives them a chance to talk about the feeding problems that they've had. So this is much more a focus on the difficulties they might have had or the difficulties they're currently having, and they can just have a free text for that. That's kind of what you get anyway. You'll get a long, 5-paragraph email sent to you, not 2 paragraphs. When someone's asking for that support in the first place, they naturally want to tell you all this stuff. And then at the end of that, you want to know the basics of the last 24 hours. How many feeds has your baby had in the last 24 hours? What was breast milk? What was formula milk? What was express milk? The frequency and the volumes. So that's in the 24 hours prior to them sending you that form. Because if we've got a baby that's feeding 16 times, we can see a problem. If we've got a baby that's feeding 4 times, we can see a problem. So you're starting to form a picture before you've seen them. You can do all this in person. Obviously, it makes the consultation a lot longer and there's a lot more writing during it, which is why I gather it beforehand. But you can do that in the 24 hours prior to the consultation as well. Then we want to know nappies, wheeze, poos, number, volume, colours, concerns. They mustn't be having the next class. We've definitely gone into their time, otherwise they're all sat waiting.
Sorry, what is the next class? Sorry.
I don't know. I just know that Lizzie says to me I need to be done by 7:30 because she has a class on a Wednesday. So I haven't checked, so maybe there isn't one. I didn't check it.
So
I just assumed.
Do we automatically go into the next?
I mean, I'm thinking it mustn't be on because they'd have started. I'm literally stealing their time right now. So I'm thinking it would have been a 7:30 class and they aren't here, so.
Oh, right. But it's the same link, right?
Yeah, it's the same. So if I go off and it was still somebody else would start it, but there doesn't seem to be anybody saying get off the link. So normally I get messages saying I'm trying to get on the link.
Right.
So yeah, sorry about that. Is there anything that anybody else wants to ask me before we finish? Have you found it helpful? Is it useful?
Yeah, very practical.
Really
I'm pitching it right because I say this is the first time I've done these tutorials in this way. I'm usually a right little PowerPoint gal, so I just want to make sure I'm getting it right based on what's helpful for you all.
Really interesting. Thank you.
Okay, good.
Right. Thank you.
Good. Thank you for that. It just means that I know I'm doing it right. I'm really good at taking feedback. I mean, I go and hide in a corner and cry for a week when I've done something wrong, but then I pick myself up again and I figure out what to do so nobody can criticize me ever again in the rest of my whole life. The ADHD dysphoria of rejection is real. Okay, guys, thank you so much. If there's nothing anyone else is desperate to ask me, you've got my email address. For those that haven't met me before, I'm just going to pop it back in there. I'm also going to give you my phone number for WhatsApp. We don't have a WhatsApp group. It's something I'm working on with Lizzie. She gave a really good reason for it, but I don't know why we don't have one. I can't remember. But I do have genuine ADHD, which means if I read something and I'm busy, I'll always intend to reply, but I might not. So I'm very happy to take nudges, very happy indeed. So I'm either really great and I reply instantly, or you have to nudge me a couple of times, okay? But I always want to reply. Is that all right, guys?
Yeah, absolutely.
Take care. Have a really good rest of your evening. I'm off to the supermarket now. It never ends. Bye, folks.
Thanks very much, Rebecca. Thank you.